Thank you very much. It's an extreme honor to be here today to be able to present some of the work that we've been doing at the University of Florida. I congratulate the committee for having the vision and foresight to actually develop a meeting centered around aligner therapy. I've been involved in it for quite some time, since its inception, and it's as Graham mentioned, it's grown by leaps and bounds, and I just want to go over some of that with you today. First, I would like to disclose that I am a consultant with Align Technology, and I've received research funding from them as well as also from OrthoExcel Technologies. A little bit about me. I'm at the University of Florida, which is in Gainesville, Florida, which is about, is this working? There we go. Is about 2 hours north. For most people know where Disney World is, and we're about 2 hours north there. And I actually live at the second star over here on the west coast a little bit more in Panama City, where my wife, Lauren, who's here today to share Valentine's Day with me, is here as well. She's an orthodontist and has her practice there as well. It's about a 4-hour commute for me, but I commute that on weekends and not during the every day. We've got a very beautiful campus, many nice buildings on our campus. It's quite a large campus with all the different undergraduate programs and graduate programs. We have sports stadiums as well. And we do have a lake in the middle of the campus in which to have our alligators, and that's our symbol, is our alligators, and they are located in there. The Health Science Center is also there, which is quite large. Has a number of different hospitals on, and the dental school is this building right there, is the red brick box there right in the middle. And it's quite a pretty campus. What I'd like to do today is describe some of the clear aligner products that are actually on the market and talk a little bit about those and how the factors they interplay with each other that may impact the tooth movement that we're trying to create with our aligners. As everybody really knows, it started back in the philosophy of just tooth movement itself with the positioner that Kessling had developed back early on in the 40s. And when this first paper came out, I don't think there was any vision of having the type of therapies that we have right now, but this was the method in which teeth were just cut out, repositioned, and then a positioner was developed. Later on, late 90s, when it was first developed by Align Technology, one of the first papers that came out of there was by Vicky Velasic and Bob Boyd, and it was dealing with a simple malocclusion, just simply malaligned teeth. And here's a picture of the first ClinCheck at that point in time, the first models. Hard to believe in just 16 years we've gone from that to what we have right now. But this was affectionately referred to as the Stonehenge model, and I think you can see the resemblance there. The finished case then being there, as you can see. Since that time, aligners have grown by leaps and bounds, and there's all different types of products out there at this point in time, with a lot of products that we had prior to that now wanting to be called aligners. Because when aligner therapy first came out, a lot of people tried to keep their distance from it, said it would never work, and it wouldn't be an accepted technique by orthodontists. Little do we know now as to what has happened since then has changed all that. But what has developed are this very large plethora of type of aligner products that are out there. And what I've tried to do is assemble those into these 6 different categories of products, taking them from when we started in the beginning, of which we well know as guides and positioners. And these are the products that have been out there previously, the AOA positioners and the pre-positioners and those things that are used just to modify teeth, of which we were familiar with before. Then there's the activation aligners, those I call the activation aligners. These are the aligners that you create a liner, but then you may have to make changes along the way, and you're able to activate those in some ways, such as using the pliers that are used to cause a dimple in the windows technique that first came out with Jack Sheridan early on. And again, these are techniques that were well known, but for doing very, very minor types of tooth movement. Then as it grew, we have the capability then to make impressions and actually do manually resetting of teeth. Okay, quite a tedious process, but there are products out there that use this in order to develop their liners. And while this is probably not a complete list, because the list is growing and growing, growing almost on a daily basis, if not a weekly, and so this is just some of the products that are out there. But the overall characteristics I've tried to list here are really dealing with minor tooth movement of upper and lower anterior teeth. Generally have 3 to 5 aligners in their system. Very few of those will have some attachments. Those that I'm aware of that do have some attachments with these types of aligners are listed there as well. And may have different types of aligner materials as well. Then we get to the bigger picture where we can do a little bit more refinement in our tooth movement. And those are the digitally reset teeth. These are the ones in which we get some type of a 3D model. Those teeth then are separated with digital saws in order to develop individual teeth in a digital manner. We have some type of software in order to do our digital treatment planning and move those teeth. There's methods out there then to fabricate our three-dimensional models that are necessary for each stage. An aligner is then produced, and those are then delivered to our patients. So these are our digitally reset models. Now, those can also be grouped into different types of aligners, in which we have those products which are exclusively dealing with minor tooth movement. And those will be aligners that are generally less than 5 aligners. And some of those products, again, are listed there. And as I said, they change rapidly, and so those might not necessarily be complete. But they'll usually have less than 5 aligners. Doing a little bit more moderate type of tooth movement listed there, up to 10 aligners. And then there's a growing category of aligner systems out there that are doing more and more complex type of movements, to the point where nowadays there's almost not any type of treatment that we can't do with aligner therapy. The in-office aligners, that's a growing segment of the business at this point. There's methods out there now for image capture, formulating the 3D models. There's treatment planning software, methods now to do the models within the office, and then also aligner fabrication. So if you would like to, you can fabricate your own aligners in office. And then a new sector that's growing is at the at-home. And these are when the companies that teach the patients how to take their own photos, take their own impressions, they send those in, the company sends back the aligners. And that's how we'll talk about that. And then there's things that we need to consider in tooth movement. And we do this whether it's with fixed aligners, fixed appliances, or with aligners. And you're all orthodontists, you know that. And when we treat a patient, we've got variables within that patient. But generally with a fixed appliance, we can modify things along the way, which is much different than what we can do with aligners. So those variables I tried to list here, and I'll just speak to those a little bit. But then there's the aligner variables that I also want to touch on a little bit on into my presentation today. Things that I think we need to start thinking about a little bit more when we're treating with aligners and how they may impact with the tooth movement and our outcomes. I'd be remiss if I didn't refer to a systematic review, of which one author was Tommaso here, of which looked at the state of clear aligner therapy at the time and looked at the entire literature, and as a systematic review does. And I was happy to see one of our papers was listed there. It had a B grade because of the way a systematic review does and looking at how the trials are set up. But the overall end conclusion of this, which is correct, is that there isn't very many good papers out there looking at, and especially clinical trials, looking at tooth movement with aligners. One of the reasons maybe in dealing with clinical trials, which is the really method that needs to be done in order to look at our outcomes, but with a clinical trial, you take a population and you randomly divide this population into a control group and a treated group. And then with these, you would treat them with the same treatment protocol and ultimately look at their outcomes. Well, in orthodontics, that would be great. The one problem we run into is that orthodontic treatment generally takes 18 to 24 months, or if you've got more complex cases, may even take longer than that. If you're looking at very simple type of treatment, that may be a different type of question that you're actually asking. But clinical trials can take quite a bit of time, and by the time the trial's done, think of what's happened in aligner therapy just within yearly intervals, and the materials, the questions that might have been asked might be not worth anything at that point in time. As a result, what I tried to do back in our lab is to develop a model that which we could look at tooth movement utilizing aligners, but doing it in a shorter period of time to get some answers on how teeth move with aligners. So I developed a tooth movement model in which we were just moving one tooth, a single tooth. And I could move that tooth then over any increment of period of time that I wanted to. In this case, it was 8 weeks. And I would apply the force. I could look at any type of tooth movement that I wanted to, and this is just merely a tipping tooth movement of the upper central incisor. And then we can take either our scans, at that time it was impressions with PVS, in order to look at the outcomes, and you can see that the picture and the actual model look the same there. Well, we can do this over a period of time and then collect data at any interval that we want to, and these were actually weekly scans done on that patient over an 8-week period. We then take those, we can plot those on the patient, plot them during that 8 weeks. At this point in time, we had taken away the aligner. You can see what happens to the tooth after that period of time. Here's the plot of a second patient, and you can see that there's difference in patients. How many people have seen that in patients with any appliance, no matter whether it's fixed or aligners? We have that. The one beauty of a clinical trial is that you have a bunch of patients, and this is the point where these aligners were changed during this trial. And if you plot all 40 patients together on a plot, you can see the amount of variation that you can get in a population. And this is why a clinical trial needs to be done on a population, and you really need to look at populations rather than just an individual case or a case studies, because those become very, very selective in the cases that you actually present. And you can see in this, there's actually patients that did not have much movement, did not work at all. And that may be due to compliance or other reasons, okay? Same type of factors we would run to in our office. So these movement considerations become very important. And what I'd like to do is just touch on the patient variables very quickly here. Some of these are in fixed appliances, but as we know, with age, teeth move faster and a faster rate in our younger patients. That's nothing very new. But what we actually looked at was age and gender difference in one of our tooth movement models. And this was in a human model, using that model that I just showed you. And what we saw was that in 18 to 35-year-olds, the tooth movement rate actually started to decrease during that age time. And then it leveled off between 35 and 50. But then, as it got to that 50-year-old, we saw something that was pretty interesting. It then started to decrease in the 50 to 70-year-olds, but with the exception of the women in that case, okay? And tooth movement then rate would actually increase, okay? Reasons for that? Well, we know women become osteopenic at that age as they hit menopause. So if there's no drugs being taken in that in order to eliminate that type of thing, we saw that type of movement. And this is from a model. Not every patient follows this, but again, it's a population, and it's from a model that was derived from all that data. Again, that's information that we probably don't use even in our fixed treatment, much less our aligner treatment. Periodontium, I think this is probably well known. I just list this here, but this was actually in a mouse model because you can't necessarily stimulate overall periodontal disease in a human model ethically and then look at the tooth movement. But with inflammation, and there's a process with the change in the osteoclasts and the components involved in that, and you get a significant reduction in tooth movement. Root variation. I think we're, again, aware of this within fixed, but root variation plays a role in tooth movement and probably could alter our movement in our aligners very easily. This is a study that looked at changes just simply in root size and shape and found that as the root changed, that actually the center of resistance changes as well. And so as a result, when you have a shorter root, that results in less, a shorter root or bone loss that from periodontal disease, you actually have the center of resistance change and it results in tipping movement, more tipping movement. Okay? How does health affect our tooth movement? Again, a few different diseases that are listed here, but something we need to pay attention to. The periodontal health can be well affected by diabetes, osteoporosis. Smoking affects it. All will affect tooth movement one way or the other. And then overall bone metabolism as well with diabetes and osteoporosis. These are just a few examples of that. How will drugs impact? There's numerous drugs out there, and I don't think we necessarily know the effects of all the different drugs on tooth movement because it's not something necessarily the drug companies will even think of, but we have to look at bone turnover and tooth movement. And these are just some of those that will actually increase tooth movement, some which your patients may be on, such as PTH, thyroid hormone, and things like that, that will actually increase our rate of tooth movement. There's those that also decrease. Okay, and some probably are not new to you as well, but ibuprofen or bisphosphonates, and it's ibuprofen in these cases, which is long-term. Okay, because as we find, but there are some such as antioxidants or statins; those are taken for drugs or different types of diseases. That if our patients, older patients, are on, it's not only age that we're worrying about with tooth movement, but also the drug medications come into play and how that alters tooth movement. Then there's a huge list, and it's just a few again that will actually have no effect on tooth movement whatsoever. And we'll go out and we'll tell our patients to take some type of pain medication at the time. And I know there's some orthodontists that worry, well, don't take ibuprofen or don't take aspirin because it's going to decrease your tooth movement. What we're worried about is the long-term taking of that type of drug and not just taking it for individual instances of pain, because that will not affect tooth movement. Genetics can play a role in tooth movement as well, and this is just starting to be looked at. This was a paper out of Lori Iwasaka's lab, and actually found that there's a genetic loci of this different allele that is necessary in order to increase tooth movement in the animal model that they were looking at. So this is something in the future that we'll also be looking at, and in order to determine how rates of tooth movement might be affected. So that's an overall listing of some of the things to think about of patient variables. Not a lot of these are new to you. We think of them often, not necessarily in depth if we're using a fixed appliance, but probably should think of these a little bit more when we're using our aligner therapy as well, because I know for the most part, we just prescribe our aligners. Well, here's your aligners, wear it this period of time, change it this period of time, and everybody gets the same prescription in order to for their aligner wear. But it's probably we should think about this with each individual patient. So those again are the list of the patient variables. But how about the aligner variables? I don't think many people think of these as, at all. And we've got all these companies out here, all these different types of aligners being fabricated and delivered to our patients. So what do we really know about those? And are they all the same? And are the only differences in them cost? But think about program rate of tooth movement. Some have attachments, some don't. Why? They're different shapes of attachments. Length of time the aligners worn, is that important? And the aligner plastic, which we'll talk a little bit about. So these are those variables that I had just listed there, which really become into play, but the questions that come from that are, how often do I change the aligner? How much movement per aligner really is necessary? Are we able to get? Should I use attachments? And if I do, which attachments should I use? And what about the aligner plastic? Is everybody the same aligner plastic? Is there any differences? All right, so how often do I change the aligner? I've seen you talk to people that are using different aligner systems. I hear everything from I have them change them every 2 to 3 days, up to every 3 weeks, most being in the 2-week range. But you hear all these different things. And if we look at one of the experiments that we did, and this follows for quite a few of the experiments, in fact, you will notice that these are just a plot of what's going on. You'll notice that the line is not necessarily straight all the way, but you'll notice that during the first week there's a steep slope, then it kind of levels off, and then it follows that for the next 3 increments there. So we see different type of tooth movement during those 2-week increments. And what's going on is that those black arrows is actually where a new aligner is being given. Okay? So it begs the answer, what is going on during this time? Are we able to increase our movement by actually giving a new aligner? And is that second week nothing happening? Or, if those of you who are probably well aware of the tooth movement model, is that during the time, is that necessary for repair of the periodontium at that time in order to undergo further tooth movement? And it's just a limitation of biology alone. And we haven't fully looked at that question. But you can see here, there's something that goes on that would then necessitate actually asking that question as well. But then you put into the variable of that, well, how much movement per aligner do you do during that 1 or 2 week period? And different aligner systems that I have listed here, these are the things I can find out from their systems. A lot don't necessarily list anything, but you can see they list anywhere from 1 millimeter per aligner all the way up to, well, it just depends on the number of aligners and how much movement we're going to get. But many are under the 1/4 millimeter mark, okay? But you can see there's a huge, huge range in the amount of tooth movement that some companies will do per aligner. Something to think about as well. We looked at that a little bit in that we used the aligner system in order to look at a 1/2 millimeter of movement per aligner and a 1/4 millimeter of movement per aligner. And this is the plot of those during that period of time. And I think you can see that, and I don't think you would necessarily have to be a rocket scientist in order to determine, well, you're going to try to program it with more, you're going to get more. Versus that you're getting with the 1/4. But with the amount that you were trying to obtain in total, is it more efficient? Okay? Is it more effective during that time? And with the 1/2 millimeter, we were only getting 55% of what we were trying to get, which is a total of 2 millimeters during that time. Whereas with the 1/4 millimeter, we got a little bit more. We got 61%. Okay? Again, these are on average. Remember the variation that I showed you that can occur in any trial, but this is on average. You can get a little bit more effectiveness with the lower amount. And these are the same type of plastics, everything else being the same in these patients from a clinical trial in which the age groups are the same and that type of thing. So again, thinking about a clinical trial being done with all the other variables being the same. How about attachments? Some have attachments, some don't. some have different shapes. What role do they play? And this is just some of those that I could find that list that they use attachments, and there's very, very little data out there right now on attachments. One paper came out in 2014. They were looking at simply canine movement, and when we try to move a canine, how closely does it come to resemble translation and not just tipping? And they found, using a finite element analysis, that with the attachment that they had, that it would resemble translation that we usually see with fixed, but without it, it was just purely tipping. So the attachment became very important in the type of tooth movement that we were going to get in this particular model. The other paper that recently came out was looking at attachments and how well the aligner was able to retain onto the teeth so that it can then express its tooth movement. It looked at two different types of attachments, an ellipsoid and a bevel attachment, and what they found was that the ellipsoid, for retention purposes at least, was just as good as having no attachments at all. It just basically came off. Okay, so for retention purposes, it wasn't any good. Whereas as with the beveled attachments, it aided in retention better. And retention itself is important because if that aligner doesn't stay on, you're obviously not going to express the tooth movement. So this has nothing to do with necessarily expressing the movement itself, but there's everything to do with the retention of appliances. So this is just a summary of that. Attachments are important. The design is important as well. Optimized attachments came out from Invisalign, and these are engineered in order to deliver the force that's necessary, and they're very, very different types of attachments, and they're specific for the tooth surface and the type of movement, and they've recently come out with maximum anchorage type of attachments, which I just started. I've got some patients almost completed with, and again, those work very nicely, so there's a lot of work going on with attachments. The aligner variables, plastics, okay? How much do we think of plastics? I don't think we think very much about it, and there sure isn't very many questions being asked about it because there's very little of it that we can even find out from a company because much of it's proprietary. And everything from copolyester types of materials, we've got hard and soft materials going on, we've got copolyester PETGs. What role do those play? Are they important in our aligner movement? Invisalign has the Smart Track multi-layer polyurethane material out now. And Clear Correct, Vivid, what's available also for in-office, many of the labs are using is this Zendura, which is a rigid polyurethane type plastic. How do they differ? Well, there's, again, little data out there that plastic is important, and in particular, when we examine plastic, we want to look at it in the environment that it's going to be used at. And one thing this showed is that at ambient temperature versus at body temperature at 37 degrees, the plastics are quite different in the properties they display. So you want to look at it at the temperature we're going to be working at it. And also, the relaxation rates can vary between plastics. And so you would probably want a plastic that has a lesser relaxation rate, and they found that in a couple different plastics I have in that big box there that don't relax as quickly as other ones do. And when they don't relax, that means they're applying the forces that we need. This paper, this was the retention paper, also looked at different type of plastics and found that those were stiffer, retained better as well. Zendura is this rigid material, and they looked at wear and impact strength and found it was very, very high in the property of not wearing or not cracking very well. And so the significance, I've listed here again those variables that we just spoke about, of the little bit of thing that the data that's out there really on plastics that we know. For those of you that may be aware of what happened in one of the big shifts when line technology actually changed plastics in around 2013. And they switched from this EX30 to the SmartTrack plastic. And what it gave was a huge increase, or a larger increase in the working range. And what that means is that the plastic would displace greater and allowed the same amount of force to be expressed over the same amount of time. And so the newer material had a smaller displacement, but then as a result, the working range, though, stayed the same, even though the displacement was very much different. Okay? So with that smaller displacement was a little bit lesser discomfort for the patients at that time in particular. And it was more like a nai-tai wire is what I related to than putting in a stiff steel wire at the time. We looked at that, and what we had found was that we got a 57% improvement with the new material versus the old material in our tooth movement. So in this instance, the type of plastic was playing a very important role in the amount of tooth movement that was actually being expressed. I think much, again, like a nai-tai wire does. Okay, we got 57% more expression. So in summary, in the different experiments that we have done over the years, we find that in one study in which we replaced bi-weekly, just every 2 weeks, put in a new aligner, that we were getting 41% of our tooth movement expressed. If we, after 1 week, thought, well, maybe we'll put in a new aligner, maybe the plastic wore out its elasticity, so we put a new aligner in with the same prescription, that we did get a little bit more expression, and that was up to 55%. If we decreased the rate, it went up to 62% being expressed. Okay? With the new material, the new SmartTrack, over that same period of time, it went up to 77%. Now, what's important to know is that these were all done with the Invisalign material, and this last one was done with the new SmartTrack material. And then we did an experiment with the Zendura plastic and got almost 69% of the expression of what we were trying to obtain. Okay? So I think you can get an idea that all those different variables can play a big role in the amount of tooth movement that's actually going to be expressed. So those questions that we asked in the very beginning can really come down to the aligner plastic being the central role around these things. That's going to affect the program rate of tooth movement, the attachments, and the length of the aligners, length of time that the aligners are actually worn. Okay? So the plastic becomes important before we can even start changing those appliances, or changing our thoughts on those appliances. Well, I am a clinician, okay? I've shown you a lot of data, but what I'd like to show you is that I actually do treat patients, and I utilize some of this information in treating my patients. In particular, here's one case in which I think you can see the individual has quite a bit of crowding on both upper and lower. It is a class 1 malocclusion, but this individual is a 60-year-old male. He's not on any medications. He's got good health, good periodontal health as well, and he does have long roots, as you can see in the x-rays. Okay? Now, does that amount of crowding necessitate extractions? With the shape of the arch and the lower incisors or lower buccal segments just caved in lingually, we thought we could upright those and simply end up with a good arch form and create enough space along the way in doing that non-extraction. So that's what we did. And I prescribed for him 2-week wear. Why? We've got a 6-year-old male, older male, in which, if you remember, the tooth movement, according to our data, overall, on average, is going to move slower on an older male. These are just those ClinChecks, and they're set to be they're moving automatically. You can see what was going on. You can see the buccal segments are expanding here. You can see the different attachments that we had on, and that there goes the other one there too, and that we were taking the lower incisors forward as well. Okay, no prescribed IPR on this case. Okay, now having said that, I usually do IPR along the way to make sure contacts are light enough so that the teeth can move. But I'm not prescribing IPR along the way that I have to reduce it in order to fit the tooth mass into the arch form. Here he is. He started aligner therapy on October of 2014. As I said, he had 2-week wear. And this is just taken, here he is in treatment. This was just taken last month on January 6th, 2016. And he's been in treatment 15 months at this point in time. And you can see his bite's not fully settled in. He's not done yet. He's gone through his initial aligners along the way. And I do a mid-course correction on virtually everybody. It's so easy to do nowadays. It's just my finishing bends. Sometimes, or not even sometimes, quite often I do more than one, because these are the way I'm doing my bends and my aligners, because as I showed you on that earlier data, there's so much variation in between individual patients that you're not going to get the same outcomes in everybody, and you might have to do other things in order to get the outcomes you desire. So we're doing a mid-course, and those aligners we actually just delivered. He came in this past week, and what I do with these type of situations, you can place attachments in order to erupt those teeth into occlusion. But if I want to do it more efficiently, of which this I did, and a little bit more efficiently with time-wise, I'll actually do precision cuts and put buttons on those teeth and have the aligner actually be moving to erupt those teeth, but be using mechanically a rubber band actually to bring those into place. So it happens quicker than with just the attachment. Here's another patient. This one, as you can see a little bit closer up, has this crossbite on the left-hand side. And you can see his age here. He's 14.9. And to correct that, I thought, well, I got almost a 15-year-old. It's a unilateral crossbite. He had no shift or anything. And I thought, well, I'll go in with a quad helix and simply try to control everything so I get the expansion on that one side. So I had him use a quad helix for 3 months, and I couldn't get it. And he was anxious to get the rest of his teeth going, so I said, well, the heck with it. Let's go ahead and get you started with your aligners. And now he's 15.1, and this is what I was starting with, and you can see that the change with the quad helix was really nothing, so it didn't do anything during that period. And so I got a 15-year-old male, good health, good perio, normal roots, and what do I do with his aligners at this point in time? Everything was good, so I was going to prescribe 1 week wear for him, even with the jump into the crossbite. And here's his ClinCheck. And you can see the tooth in the cartoon move very easily, right? And they move right through the other teeth, and you don't have to worry about interferences and that type of thing, where in reality you have to deal with those types of things. Sometimes more so in certain patients than other patients, that becomes important. With him, I didn't have to do anything in order to exclude his teeth in order to jump those crossbites. But what you will see on these teeth, I had a class 2 elastic. This is a cutout, a precision cut for a class 2 elastic. But also I have 2 precision cuts on the buccal segment here, of which in this you can see again, they are here, okay? But also on the lingual, I had 2 precision cuts, and what I put at those precision cuts were buttons, and I had him wearing crossbite elastics. All right? You can also see on the lingual, I had 2 attachments in order to control the expansion of these premolars. So I was correcting this crossbite by expanding unilaterally. Obviously, this whole rest of this arch is being utilized for anchorage, but with crossbite elastics on the molars. Why? Well, you could have used attachments on the lingual as well. It gets to be a little bit more difficult getting those aligners in and out, but even more so, those teeth are bigger roots, and I want a little bit more of a force than probably the aligner can apply, so I have the crossbite elastics on both those, and then that's probably assisting also with the premolar, but I have an attachment on the lingual there. What happened with him? 1 week wear. This again was just taken January 6th, so just in the last month, and you can see how that corrected by simply that. This is right when we did our mid-course scan, so all his attachments and the buttons have been taken off, and we take photos that are sent in at that time. But you can see overall his arch, it's not the only thing we're doing is crossbite correction, but developing the arch form as well, and taking care of other crowding issues, as well as the crossbite on this side. And just delivered his new aligners 2 weeks ago, and I haven't seen him since. But again, he's continuing on with 1 week wear. So we're in the treatment in 4 months and took this malocclusion, and we're probably done in 8 to 10 months overall of treatment. Okay. So overall, our aligner therapies have come quite a ways. It's far from the braces that we've done over the years. Aligner therapy is here to stay. And again, I'm honored and pleased to show you some of this information today, but honored to be a speaker at the first aligner meeting that I think that anybody's ever had in the world, and so I congratulate you for that. Thank you very much.